Welcome, everyone. This is another one of the modules that are a component of our financial literacy program developed here at the Alpert Medical School at Brown University. My name is Dominic Tamaro, and I'm Vice Chair for Education in the Department of Medicine based here at Rhode Island Hospital. Our financial literacy curriculum really runs the gamut from the basics like how to read your paycheck to more advanced financial planning aspects. Today, we're going to talk about something that every physician needs familiarity with, and that is malpractice insurance. And to cover that topic, I have two experts in the field, and I'm going to let them introduce themselves.
Hello, I'm Rick Almeida, Director of Property and Casualty Insurance for Brown University Health. Been with Brown University Health now for 26 years. I will be more involved in the second module. We will be able to ask questions related to specific malpractice questions for Brown University Health.
And my name is Joan Porcaro, and I serve as the Senior Vice President for Risk Services for WTW Willis Propine. And background-wise, I've been with Willis for over 5 years and have worked in the healthcare world for over 30 years, specifically focused on risk management in all settings, whether they be hospitals, physician practices, and such. And I'm a nurse by trade, but have also been certified as a risk management professional. And so really appreciate having the opportunity to speak with you today with regard to medical malpractice insurance. And as medical students, residents, fellows, you are trained to focus on delivering excellent patient care. But really, every clinical decision you make also exists within a legal and a professional framework. Medical malpractice insurance is one of the key systems designed to protect you, your patients, and your ability to practice medicine over time. And in this session, Module 1, we intend to demystify how malpractice insurance works, explain the differences between policy types, and highlight why certain decisions, often made really early in your career, can have long-term implications. The goal here is not to make you legal experts, but really to give you enough understanding to ask the right questions and to avoid common pitfalls with regard to establishing your medical malpractice insurance. So I think, really it always is a good place to start is at the beginning. And medical malpractice insurance, truly, it does exist to protect healthcare providers from financial and professional consequences of the claims that may come about in your career where negligence may be alleged or there's an error in care. And at the same time, it really supports patient trust by ensuring accountability and providing a formal mechanism for when compensation may need to happen if harm has occurred. When we look at it as far as the importance, it really is part of your clinical practice, and it's essential to your practice because it not only protects your finances and your ability to continue to practice, but it ensures your professional standing. And it also enables credentialing and employment, and it supports risk management through, education and legal resources. And especially critical in high-risk specialties where exposure could be greatest. So we're spending a little time on policy types, and it can be sometimes a little bit confusing. We've got several examples here to take you through. So when we're looking at medical malpractice insurance, we're looking at a couple key areas. You'll hear the terms claims made, occurrence, and tail coverage, and nose coverage, and each differ in when and how your medical malpractice insurance coverage is triggered. So understanding these differences is critical because policy choice affects long-term protection. Decisions made today may not be realized and activated until much later. And two, you might be changing jobs, down the road retiring, or having to report a claim after a policy ends. When we're thinking about this, I will say that it's always good to use an analogy, and we try to explain medical malpractice insurance like a subscription service. So on claims made, if you have a subscription, you're covered only while you're subscribed. Occurrence, another form of insurance, is you're covered forever for what happened during your subscription. Tail coverage is you bought a little extra time on that subscription that you will have. And so when we're really doing a deeper dive on claims made, we talk about it within an umbrella, if you will. There's three key terms that drive how protection works. And there's a retroactive date that can set how far back incidents can occur, while nose and tail determine how coverage continues when carriers change or your policies end. And understanding these concepts is critical because a gap, perhaps in a retro date or tail coverage, can leave providers personally exposed for past care even years after it's delivered. That is, you're switching insurance carriers and the new carrier extends coverage to your potential future claims. So it's not meant to be as confusing. I like the visual of retro, nose and tail to really help kind of bring the point home. Now, when we're looking at claims made, and we're going to have a lot of different examples here to kind of drive the point home, it provides coverage only when the claim is filed during the period the policy is active, as long as the incident occurred after the retroactive date. The important thing to emphasize is really timing. So even if the care or event happened years ago, no coverage applies unless the claim's reported while the policy is in force. That's why claims made coverage is often compared to what we mentioned before, a subscription. Once you stop paying for the policy, access to coverage for past incidents ends unless you take these additional steps. And that may include purchasing tail coverage, which extends the time you can report claims after the policy expires. Tail coverage becomes really essential, particularly when you're, as a physician, you might be retiring, you're leaving a particular practice, you're changing insurers. And again, without it, any future claim tied to past services would fall into a gap with no coverage. So understanding this mechanism also will help when you're working with different organizations, whether as an independent community physician or as an employee. So it's important to know all the aspects of insurance, no matter what the job status is. So some considerations about claims made policies. And again, we mentioned that it's for claims filed during the active policy term. The structure differs from occurrence-based, which we're going to cover in detail shortly, really making it essential for professionals to understand really the timing requirements. And the critical role that the tail coverage will play is one that will present a risk for the professional physician to being exposed to claims that may have happened long before. Now, when we talk about claims made, and if you're a new physician, it often starts at a lower premium compared to occurrence policies. But the cost of tail coverage can also be substantial when tied to your claims made policies. Sometimes it amounts to several times the annual premium, so budgeting for this expense is going to be key. And ultimately understanding how claims made coverage works, its limitations, cost implications is vital for effective risk management and long-term financial planning. A couple case studies here. There's an example of a physician here who had a claims made policy that started in January 2023 and had a retroactive date of the same day. And as the story goes, this example shows how a claims made policy responds when both the incident and the claim occur while the policy is active. If the claim were to be reported after the policy expires, coverage only continues if the physician has purchased tail coverage, underscoring again why tail decisions are so important when leaving or changing coverage. Example 2, we have a doctor insured under Carrier A with a claims-made policy from 2018 to 2023, but in 2024 switches to a new practice and a new carrier. And a claims-made policy only responds, as I mentioned, if the claim is filed while the policy is active. So in looking at this example, this particular scenario is really a good example for having tail coverage, which extends the reporting period after you retire, switch insurers, or leave the practice. The third example highlights a common claims-made risk. So the claims-made policy was from 2015 to 2025. In 2026, the surgeon retires, cancels the policy. A patient files a malpractice claim in 2027 for a surgery done in 2024. So this claim is outside of the active policy period, so there's no coverage unless the surgeon purchased tail coverage when they retired. Another example here is, the cost, and I want to just drive that point home that claims-made premiums do start lower and they increase over time as prior acts accumulate, claims occur, and then exposure grows with each year of practice. And while this structure helps new physicians manage those early career costs, it's important to plan for those higher mature rate premiums and potential tail costs later on. So when we're talking about tail coverage, extended reporting, regarding the slides here, it seems that, the duration and cost deserve a little more attention. And tail, to me, extends to the expiring carrier's policy and the coverage into the future. So in essence, it extends the existing policy for a defined period. So it could be for 1 year, 2 years, 3 years. And it can extend the claims-made policy indefinitely, truly, once you make the decision about what fits into your budget and what fits into your specialty and what you would like to see happen. So the more you extend the coverage period, the more expensive it is. And typically carriers can charge 100% up to 250% of expiring premium for indefinite future costs depending on loss experience. Again, the claims that were made against your policy. So really, to summarize again, sometimes you'll hear tail coverage called extended reporting period. It is an add-on that allows you to report claims after the policy ends for incidents that happen while the policy was active. It does not cover new incidents after the policy ends, only claims arising from past work. And again, the cost will be attuned to how many years you are extending that policy. So here's an example of tail coverage. A doctor has a claims-made policy from 2020 to 2025. In 2026, the surgery was done in 2024, for which the patient now files a claim in intent to sue. If the doctor didn't buy tail coverage, the claim is not covered. So it's really key to, understand that once that protection is gone, it becomes a personal liability. We'll spend a little time talking about nose coverage. And we're talking about now you've moved from one practice to another practice, from one carrier to another insurance carrier. So you may have the opportunity of, instead of buying tail coverage from your old insurer, you negotiate what's called nose coverage with your new insurer. The new insurer sets a retroactive date that matches your original policy's retro date. This way, your coverage history continues seamlessly under the new policy. So why would you choose nose coverage? Sometimes, depending on the carrier, it can be less expensive than tail coverage. It keeps everything under one policy, and it simplifies administrations, your business practices, and the claims handling themselves. So looking at this example, claims made policy from 2020 to 2025, you switch insurers in 2025. Instead of buying tail coverage from the old insurer, you buy nose coverage. The new policy's retro date, so claims for incidents from 2020 onward are covered. Another example here, you might be in a group of physicians that switches carriers under a claims-made policy. Prior acts have to be addressed to avoid losing coverage. So in this example, negotiating nose coverage with the new carrier allows the group to preserve the original retroactive date and avoid the cost and administrative burden of purchasing tail coverage. And there's a slide here that really helps you compare, nose and tail coverage both protect prior acts, but they differ in who provides the coverage and when it is secured. Tail is purchased from the old insurer at termination, while nose is included by the new insurer at inception. So again, understanding the distinction is important because nose coverage often preserves continuity at a lower cost, while tail coverage can be significant one-time expense at the end of a policy. With regard to retroactive date, it sounds pretty simple. It is the starting line for coverage, and it's the earliest point at which an incident can occur and still be eligible for a claim under a claims-made policy. Anything that happened before this date is permanently excluded, even if you carry active coverage today, which makes preserving that retro date critical when changing policies or carriers. And some key points with regards to retro, in many cases you can negotiate a retroactive date, but it depends on the insurer and your situation. So how does negotiation work? When starting a new policy, you can request the retroactive date to match your original coverage date from a previous insurer. When you're switching to a different insurer, the carriers will honor your prior retroactive date if you provide proof of continuous coverage. And when buying tail coverage, the retroactive date stays the same, it doesn't change. So some of the tips with regard to this is always to confirm the retroactive date on your declarations page. That will be the page that will describe key elements of your insurance coverage. So we have another example here, retroactive date January 1, 2020, policy active 2023, a claim filed for today for an incident in 2019, it's not covered. A claim for an incident in 21, covered because it's after the retroactive date. And then this particular example is about a family medicine, physician who essentially purchases a claims-made malpractice policy in 2026 with the retro date of January 1, 2024, meaning only incidents occurring on or after that date are eligible. So in 2026, this particular scenario, the patient files a claim alleging the physician failed to diagnose melanoma during the skin exam performed in October 2023. So even though the claim's filed during the active policy period, the clinical event predates the retro date, so the insured denies coverage. The physician must either rely on that prior insurance or pay for their own defense. So again, illustrating how key it is to have a good understanding about all the aspects of medical malpractice insurance. So we'll switch gears now to the other type of policy, occurrence. So occurrence policies provide coverage for incidents that happen during the policy period, regardless of when a claim is filed, offering lasting protection. Now, unlike claims-made policies, they eliminate the need for tail coverage. It simplifies insurance management and reduces future administrative burdens. While these policies typically come with higher upfront premiums due to the extended liability coverage, they can be advantageous for providers with stable long-term practices. By minimizing transition complexities and ensuring you have that comprehensive protection, occurrence policies can deliver some peace of mind. And for those planning those sustained careers, it keeps the administrative tasks of changing to a minimum. So it provides for coverage for a claim that occurred during the policy period, regardless of when the claim was reported. So a case study for this example We have an OB physician covered by an occurrence-made malpractice policy, provided care in July 2023 to a delivery. And it was complicated delivery that resulted in a hypoxic ischemic encephalopathy for the infant, but no claim was made at the time of the event. But in February 2026, the family filed a claim. And because the event occurred during the 2023 policy, the policy for occurrence made applies. So this example shows how occurrence made coverage is triggered by when the care was delivered, not when the claim was filed. Because the event occurred during the policy year, the claim is covered years later, even after the job or the insurance coverage changed without the need for tail coverage. And some key points with regards to occurrence made policies. Again, what matters most is when the clinical event happened, not when the lawsuit's filed. These cases also reinforce the importance of strong documentation. From a risk management perspective, we want to make sure that that clinical rationale is truly called out in your documentation about the experience with the patient at the time of the encounter and the supervision that might have been provided. Because with claims occurrence made, you also have a consideration with regard to timing, but as claims that happen in high-risk specialties often emerge long after the clinical encounter. So the example is the infant just mentioned. Depending on statute of limitations in the state you are working in, it's important to know how long the potential for a claim may be out there and possibly arise later. So pros and cons. Claims made policies are often very appealing early in a career because of the lower upfront premiums. But again, they require careful planning due to tail coverage and long-term costs. Occurrence policies provide lasting peace of mind by covering incidents permanently, making policy choice more of a strategic decision based on career stage, your financial flexibility, and future mobility. If we look at what we can see from possible risks, with the claims-made policies, physicians retiring without tail coverage face personal liability for lawsuits that might be filed after the policy ends. Occurrence policies cover claims from incidents during active coverage, even if reported after retirement. So again, having a good understanding of where your vulnerabilities lie, depending on your current employment status, how you're employed, and the future of employment for you. So how do you decide? Well, there's a lot of factors that come into play, and choosing the right malpractice structure really requires looking beyond the premiums to the organizational structure where you're going to be working, your financial health, and the specific types of risk you might face. Risk-taking tolerance, long-term mission, the maturity of the risk management program at the organization you might work in also play a role. For the type of insurance coverage, the variables, as I said, type of policy, retro date, what type of tail coverage would you need? What are some of the limits of liability? So the adequate per claim and aggregate limits that match the scope of practice and the potential exposure you might have. And specialty risk profile. Some specialties have a higher risk profile. Surgery, obstetrics, interventional radiology are just some examples that may require higher limits or additional expense. You have state or employer requirements, costs versus coverage, and just the overall plan for the future. Where do you intend to take your career? So all of those factors come into play when you're making these decisions. And that concludes our Module 1. When we move to Module 2, we will be having a more in-depth discussion. What does Brown offer, and how does the risk management team work with you to help with the understanding of this? We'll also take questions that we'll get from Module 1 and address them during Module 2. So thank you for your time.